Good morning. As part of DNB academic program, we will be continuing with the audit presentation of MR Bangalore Hospital today. We have 3 units, so they will present their audit for the month of April. The first presentation is by Dr. Mehul Patel, who will present audit of Unit 1. Oh, Unit 2. Okay. Mehul will present audit of Unit 2 General Surgery. Come.
Outpatient summary. Total number of OPD days 8, total admission days 9, total OPD patients 995, total OPD patients new 669, and total old OPD patients 326. Total number of elective OT days are 8. Total time planned in the OT is 53 hours 20 minutes, out of which lab had 33 hours 50 minutes and open had 20 hours 5 minutes. Total number of minor OT days 9. Time in minor OT 12 hours 40 minutes. Total number of mortalities 1. Total number of morbidities 0. There were total 50 elective admissions, 23 emergency admissions, 46 elective operations, 15 emergency operations, 22 minor operations, and 1 mortality. In hepatobiliary and pancreatic and splenic surgeries, 17 cases of laparoscopic cholecystectomy were done for chronic calculous cholecystitis. For chronic calculous cholecystitis with choledocholithiasis, 2 such cases, open cholecystectomy with choledocholithotomy with choledocoduodenostomy was done. And for 1 case of a chronic calculous cholecystitis with choledocholithiasis, open cholecystectomy with choledocolithotomy with T-tube drainage was done. And 1 case of chronic calcific pancreatitis, lateral pancreaticojejunostomy was done. In gastrointestinal and perianal surgeries, 1 case of anal fissure, for that lateral anal internal sphincterectomy was done. For 2 cases of fistula and fistulectomy was done. 1 case of internal hemorrhoids, hemorrhoidectomy was done. And for 2 cases of recurrent appendicitis, lap appendectomy was done. In hernia and groin surgeries, 1 case of unilateral inguinal hernia for which TEP was done. 10 cases of inguinal hernia for which herniorrhaphy was done. 1 anatomical repair for ventral hernia. 1 anatomical repair for incisional hernia. 2 mesh extraction was done for a case of mesh infection after hernioplasty. 1 case of herniatomy for congenital hernia, and the 2 Jaboulais procedures were done for hydrocele and 1 circumcision was done. Now, for a case of perforative peritonitis, exploratory laparotomy with primary repair was done. 2 cases of foot ulcer, debridement was done. 1 case of gluteal abscess, incision and drainage was done, and 1 case of perineal abscess, incision and drainage was done. 2 cases of perineal abscess, incision and drainage was done. 3 cases of acute gallstone pancreatitis were managed conservatively. 3 cases of acute calculous cholecystitis was managed conservatively. 4 acute appendicitis were for which open appendectomy was done. 2 cases of subacute intestinal obstruction were managed conservatively. 1 foot cellulitis with compartment syndrome for which osteotomy was done, and 4 cases of diabetic foot ulcer for which debridement and dressing was done. In minor OTs, 7 cases of sebaceous cyst excision, 5 cases of lipoma excision, 2 cases of granuloma excision, 3 cases of dermoid excision, 1 case of skin tag excision, 3 cases of corn excision, and 1 bursal cyst excision was done. When 1 chest drain was inserted, there was 1 mortality. Mortality 1. A 60-year-old male came to the ER with features of subacute intestinal obstruction, who was a known case of hypertension and ischemic heart disease with a history of 5 days. He was resuscitated and was planned for radiological investigation. On day 1, he developed sudden respiratory distress and chest tightness. SpO2 was 83, TROP-T came out to be positive, and anti-proBNP was 1400. He was shifted to CCU. Resuscitation was tried, but the patient did not respond and succumbed to death due to acute cardiac injury. Thank you, sir.
Go back to the admission slide. Admission. Repeatability. Yes. Yeah. So in two cases of CVD stone, you have done choroidostomy, and one you have gone with the T-tube drainage. How do you select patients whom to do choroidostomy or T-tube drainage?
So it's on the consultants.
It's not consultant. It should be some points that
So
you decide to do.
We should do T-tube drainage.
Always.
That's
what I'm saying. When you are assisting, you should try to understand why a decision is taken for doing a choroidostomy for a particular patient. So there are some specific indications. You see, if you find the bile duct is dilated, 1.5 side dilated duct, or you suspect there is some distal obstruction, in that case, you need to do a drainage. Okay, not T-tube. It is a distal obstruction. There are multiple stones, there are biliary mud, so there is chance of recurrent stone formations. In that case, it's better to go for a wide drainage procedure. Okay, so and then chronic pancreatitis, you said lateral pancreatitis. It was just a anastomosis between the duct and the jejunum. What is the now accepted procedure for patient with chronic pancreatitis? Where is a pacemaker of pain in chronic pancreatitis? Where does most of the pain in pancreatitis patient starts from? The head, tail, body? Head. So what is the recommended procedure? So LPJ is a standard procedure, but people are saying that unless you pull out the head was head coring done? Yes. So what it becomes in head coring plus LPJ. The operation goes by the name of freeze procedure. So you should say that it's a freeze procedure. Correct. You see, when you mention that there is no morbidity, you see, you are operating 40 major patients, you are operating so many emergency patients. So I don't agree there is no morbidity. The point is, in day-to-day practice, you are not noticing. What is morbidity? In a post-op patient, you have a road to normal recovery. So any deviation from the normal recovery is morbidity. Someone having a wound infection, someone having a prolonged ILS. You have done 17 lab coli. Some patient may have a biliary drainage for some duration. So there are morbidity. So point to say that if you say that I have done 60 operations, then zero morbidity, that is not a usual situation. So you should keep in mind the idea of discussing the whole audit is what is happening in our patient population, what is the standard of care, and what else could have been done about this morbidity or the mortality. This mortality is an elderly gentleman. What do you think this patient died of? He said cardiac injury. So he had a cardiac existing disease, I agree. And then he presented an obstruction. What management can aggravate his cardiac symptom?
Excessive fluid.
Yes. So one should be very cautious. When you are resuscitating a patient having a cardiac disease, you should be very cautious. In this patient, you should at least do some invasive monitoring. Otherwise, in a patient obstruction, you say give 1 liter challenge. This patient will have cardiac failure. So one should always keep in mind that whenever you are dealing with a patient, it's not that everything goes by routine. You have to add the patient status in mind and then think of this resuscitation system. Okay, so the whole idea of audit presentation is how we are going, how we can change. Okay, so in all the patient, none of the patient has a minimal minor infection in your whole practice in 1 month. So there are then these are morbidities. If you have, that's what I'm saying. Don't say there is no morbidity. You try to understand how this any deviation from normal recovery is a morbidity. So it can be so many things. Some patient may have chest complications. Some patient may have post-op cuff. Some patient, if you do a chest X-ray, you find there might be some atelectasis. Particularly elderly patient, this happens. Okay, so keep in mind that. Then keep going, keep going. Dr. Kaur, you like to have any comment?
No, nothing. Nothing. You're absolutely right.
Yeah. Yes. Come to the hernia. You see, I find out of almost 15 cases, 19 cases, 10 cases has herniorrhaphy. What is a herniorrhaphy you're doing? Because anatomical. What is anatomical?
So,
in inguinal hernia?
no, sir, darning and posterior wall repair and darning.
You see, darning is a form of hernioplasty. Try to understand. If you are just opposing the conjoined tendon to the inguinal ligament, that is a rhaphy. That means you are just opposing the conjoined inguinal ligament. And if you are saying you are darning, darning means you are keeping loose threads in between the conjoined tendon and the inguinal ligament. What is the rationality? Why unit is following? Because now the standard of care is Liechtenstein hernioplasty. That is a standard, and now more and more people are doing laparoscopical, and also laparoscopy is also now established as a standard procedure, even for unilateral inguinal hernia. If you have the facility, you have the expertise, even in unilateral inguinal hernia, laparoscopy is acceptable. What is the your cutoff for insial hernia undergoing anatomical repair? What is the insial hernia? Due to what?
Sir, due to it's a previous OT, sir.
What OT?
So coli, sir. Previous open coli was there.
Patient has open coli and that patient has developed a hernia. That is a subcostal hernia. So what if you go by the anatomical repair here, it's a different situation altogether. If you talk about subcostal hernia, here anatomy is patient has got a posterior rectus sheath, patient has got the anterior rectus sheath. If you go laterally, if you have all the layers being separate, surgical peritoneum, transverse os, internal oblique, and the external oblique. So if you use the term anatomical repair, then it has to be a layered repair of all these. What was done in this patient?
Layering all the layers.
You could delineate all the layers. In a hernia, in subcostal region, very difficult. It is very difficult to delineate this layer. Why not a mesh? I think you are very scared about mesh extraction. We have high incidence of mesh infection in MR Bangalore. I find in the beginning also I have to extract a lot of mesh. But the most important part for mesh placement is it has to be very meticulous. The hemostasis has to be very good. You should change your gloves when you take the mesh. We don't have so much infection nowadays. We are doing a lot of hernias and no herniorrhaphy, virtually no herniorrhaphy. 99% is Liechtenstein repair. So there is no mesh infection. So this is, you see, in exam, if you say I'll do herniorrhaphy, then examiner might not accept it. The standard of care is Liechtenstein hernioplasty. Okay, this may be anyone from Rahul. Rahul is there. Dr. Rai is there. No. Rahul.
Yes, sir. I'm there.
What's your opinion regarding 80%, 90% patient undergoing herniorrhaphy?
Definitely, there is a choice is Liechtenstein hernioplasty, but SAR is preferred to doing say herniorrhaphy.
Okay. So if you do darning, there is no positive infection.
No, there is chance of infection.
Okay. Okay, next. Next presenter will be by Dr. Prasenjit Basu, who will present surgical audit of Unit 1.
Good morning, our respected faculty members. I am Dr. Prosenjit Bushku, and I am going to present the surgical audit for April 2023 under Unit 2, for Unit 1, which is under Dr. A.K. Kaur and Dr. K. Chakraborty. Summary includes total OPD days 8, total admission day 10, total OPD patient 1186, old patient includes 559 and new 627. Total number of elective OT days 9, total time in OT, table 1 lab 33 hours 30 minutes and table 2 open 41 hours and 30 minutes. Total number of minor OT days 10 and total number of mortality 1, total number of morbidity 1. Audit April 20, elective admission 65, emergency admission 21, elective operation 35, emergency operation 11 and mortality 1, morbidity 1. Elective admissions, we have chronic calculus cholecystitis. 9 patient undergoes laparoscopic cholecystectomy and 1 patient undergoes open cholecystectomy. In GI and perianal cases, fistula in ano, we repeat. Fistulectomy for 2 cases. Recurrent appendix, we do open appendectomy in 1 cases, and fistula in ano, lateral internal sphincterotomy have done for 1 cases. Hemorrhoidectomy done in 1 cases. In hernia and groin surgery, umbilical hernia lap, hernioplasty done for 1 single female cases, and incisional internal hernia on mesh hernioplasty at retroactive plate done in 1 cases. In inguinal Liechtenstein tension-free mesh hernioplasty done for a single case, 7 cases, and inguinal herniorrhaphy done for 2 cases male. Breast and endocrine fibroadenoma and left breast excision done under TIVA for 1 cases, and in miscellaneous cases circumcision we did 5 cases, and in ID for periurethral abscess under spinal anesthesia, exploration under C-arm with extraction of foreign body. In emergency operation, in emergency admission, we have acute appendicitis, perianal abscess, and diabetic foot ulcer, and strangulated femoral hernia with intestinal obstruction. For which, for acute appendicitis, we did open appendicectomy and ID done for perianal abscess, and debridement done under local anesthesia for diabetic foot ulcer. And for strangulated femoral hernia with intestinal obstruction, we perform exploratory laparotomy with repair of strangulated femoral hernia with resection of strangulated bowel loop with loop ileostomy. These are the minor operation we did: excision of hemangioma, excision of pyogenic granuloma, lipoma excision, nail avulsion in a case of tonal paranoia, that is ZX procedure, and sebaceous cyst excision, excision of cone. And these are also the list above. On morbidity, we have single case and mortality 1 case. Morbidity, an 18-year male represented with chronic calculus cholecystitis. We prepared the patient and planned laparoscopic cholecystectomy. During the procedure, patient have injury to common bile duct. The process is converted to open procedure and primary repair done with 30 PDS suture. After that, patient is managed conservatively and then discharged on POD 5 after successful conservative management. And in mortality, we have a single case. A 76-year-old female presented with strangulated femoral hernia with features of acute intestinal obstruction, undergone exploratory laparotomy and repair of femoral hernia with a double barrel loop ileostomy. On POD, 0 patient is shifted to CCU as there is post-op hypoxia in CCU. The patient is treated conservatively with HFNO. On POD, 1 patient is doing well and it is weaned down to face mask with 5 liter per minute moist O2. We added low molecular weight heparin and DVT stockings. On POD, 2 patient is weaned to nasal cannula with 2 liter oxygen. POD 3 patient is doing well, parabdomen soft, IPS, polas, but stoma is still non-functioning and hypoxia is still present. POD 4 sips of water allows stoma become functioning and liquid diet trial done. On POD6, the patient suddenly deteriorates and saturation falling down. She is put on invasive ventilation. On investigation, she is provisionally diagnosed as a case of pulmonary thromboembolism, and patient developed cardiac arrest and succumbed to death. Thank you, sir.
Okay, studying the mortality, go back. So this patient was on LMWH in the post-op period.
Post-op period, POD1 we added there.
So how did you diagnose that this patient has got DVT and pulmonary thrombosis? What is the pointer?
Sir,
Patient has sudden respiratory
Huh.
something.
on T-dimer is raised and ProBNP is raised.
Yeah, clinically, patient has swelling in the legs.
Yes, sir.
Because
Bilateral
you have
pedal
studied the
edema.
patient on LMWH or first post-op day.
Yes, sir. Bilateral pedal edema is there.
I was wondering that in this patient, what is the pre-op diagnosis? Because you see, most of the time it is very difficult to diagnose a femoral hernia pre-op. Could you diagnose this patient?
Yes, sir.
Could you diagnose the patient pre-op?
Perform CECT examination, and it is CECT
No, no.
proven.
What is the pre to diagnose? You see,
It
if
is
you could
present
have diagnosed clinically that yes, patient, is any patient presenting with obstruction, you should look for the hernial sites. And patient having a triangular hernia femoral, you can always find a swelling in this region of groin, which is
Yes, sir.
below and
Yes.
Could you diagnose this patient with a strangulated femoral hernia pre-op without investigation?
Sir,
Who has seen the patient in the emergency?
sir, it is presented in OPD hours.
In OPD hours.
In
So what
OPD
was your
hours.
clinical impression looking at the patient?
Sir, there is swelling in the right inguinal region.
Oh, there is
with-
patient, there is swelling.
Yes, yes.
So diagnosis was a some groin hernia.
Groin hernia or lymphadenopathy. Then we perform CECT examination.
Okay.
That is in CECT examination they come with the diagnosis. of
Again,
femoral
then again is the next part. The patient like this being a strangulated bowel, it's a small bowel. Why do you decide to do ileostomy? Because if it is a small gut, it's not a unless there is a perforation. Patient has
So
fingerprint.
perforation is present in the
Where?
hernial site. The bowel loop are strangulated.
All this perforation in the general peritoneal cavity.
No, sir. On
So,
hernial side, the strangulated bowel loops is perforated.
Doing a ileostomy is always good to buy time, but my point is in a patient like this who has got a strangulated hernia, in that case, you can sometimes go with doing a primary excision anastomosis. What will be the hernia? How do you manage the hernia in this patient?
So repair it.
What repair? You see, if you are doing a laparotomy, you are not exposing the
Sir, we did both inguinal region is explored and midline incision exploration.
which incision give first?
Midline incision.
Then you put a
Yes, sir.
again groin incision.
Yes, sir. Two incision is made. For repair of sir.
You see, the idea of managing this patient is not managing the hernia at the moment. Okay, you manage the obstruction. And then if you see the inside, now you have a laparoscopic idea. If you look from the inside, you take a midline incision, you can see the femoral ring. If you've gone down, you can find the region of the
we tried from midline incision, but
a formal repair is not required. What I'm trying to say is you could have just put a pursing suture at the region of this peritoneal sac. Because this patient is not fit for 76-year-old gentleman strangle hernia. He's not fit for a very extensive procedure. The idea here is to just manage the obstruction. Okay.
Yes.
And if you could have managed, if there is no evidence of peritonitis, sometimes this sort of hernia can be managed just by inguinal incision. You put inguinal incision, deliver the gut.
Patient also presented features of obstruction, so we did.
Feature obstruction is because of the hernia itself. Once you can explore the hernia and take the gangrenous bowel out to the hernial sac, you can manage. Unless patient has got a generalized peritonitis, you can manage. A midline incision is not always mandatory. Okay, what I'm trying to say is you need not go through a separate groin incision to manage the hernia at the moment. Because the idea here was to manage the obstruction of the strangulation. Okay, come to the morbidity. While were doing lap cholecystectomy, how did you suspect, yes, there is a bile duct injury? What is the point that you suspected patient has got a bile duct injury?
Sir, intra leakage of bile is
You could see the fresh
evident.
bile.
Yes, sir, evident.
It-
Oozing, some oozing is
Would
present.
the anatomy be delineated while dissecting the callus triangle area?
Yes, sir, but due to poor visuality of the camera, there's some problem.
No, what I'm trying to say is,
Yes,
was the callus dissection
yes, sir.
well
It is
done
perfect.
smoothly, or
Yes.
there are some difficulty in the callus area?
This adhesion is present, and we
So you
did
find
additional
bile.
assays, and
So you find bile in this area, and you thought there is a bile duct injury.
yes, sir.
And then what you did on exploration?
On exploration, sir, with the help of 30 PDS, we did the primary repair.
Is it over a T2 or just?
No, sir, just primary repair.
You see, this is a very difficult situation. You think of a patient who has got a normal bile duct.
Yes,
Patient having cholecystitis, having a normal bile duct is a 5 millimeter. So if you have a lateral tear
yes.
and putting
It is at the junction of the cystic duct and common bile duct, just
Okay.
marginally incident.
okay, but the point is, if you have a such
Nick.
tear on the
Yes,
lateral
yes.
side, it is always safe to repair it over either a stent. You have stents or a T-tube, or if nothing is available, even for a feeding tube. You see, because often you put these stitches, this can narrow the bile duct.
Yes,
Particularly you are dealing with a normal caliber bile duct. It's very difficult to put lateral stitches. Okay, so that is this patient is how many post-op days? They could discharge the patient in 5 days.
On POD5,
Right,
after
the
repeat
point is-
LFT, the patient repeat LFT is
Right.
normal, and
What happened? Drainage tube. How much bile came in the first post-op, second post-op day?
there is no biliary
No
leakage.
biliary leakage.
Yes.
Okay.
And the serosanguinous collection is present, which is also less than 25 ml for 3 consecutive days.
Okay. Diptoman has come? No. Diptoman? Yes, send the presentation.
Yes.
Now, Dr. Diptoman Nandi will present audit for Unit 3, General Surgery.
Good morning, respected teachers and my dear colleagues. I am going to present the audit for Unit 3 surgery. Total OPD days was 8, total admission days 10, total OPD patients 952, new patients 652, and old patients 300. Total number of elective OT days 6, total time in OT plan table 1, 22 hours 35 minutes, table 2, 24 hours 25 minutes, total number of minor OT days 6, total time in minor OT 15 hours 25 minutes, time in emergency OT 3 hours, and number of mortalities nil. Elective admission 45, including 23 male, 22 female, emergency admission 17, elective operation total 38, emergency operation 7, minor operation 40, mortality 0, morbidity 2, 1 male and 1 female. In the hepatobiliary and pancreatic and splenic surgery sections, chronic calculous cholecystitis was managed with laparoscopic cystectomy, total 12 cases. Chronic calculous cholecystitis managed with open cholecystectomy 2 cases. Choledocholitis, which is managed with choledocholecystectomy, cholecystectomy, and choledochoduodenostomy 1 case. Choledochal cyst type 1, excision of choledochal cyst and Roux-en-Y hepatocholecystectomy. In the gastrointestinal and perianal sections, there was a case of rectal prolapse, which was managed with stapler rectopexy. Chronic appendicitis case managed with appendicectomy. These were 3 open cases. There were actually 2 open and 1 lap cases. Fistula is managed with fistulectomy, 1 female patient. Anal fissure managed with internal sphincterotomy, 1 male patient. In hernia and groin surgery section, paraumbilical hernia managed with hernioplasty, 1 female patient. Incisional hernia, mesh hernioplasty, 2 cases, 2 female patients. Inguinal hernia, Liechtenstein mesh hernioplasty, 2 male cases. And there was hydrocele, 1 case, evasion of sacs, phimosis managed with circumcision, 3 cases. In breast and miscellaneous section, there's a ductal CFS, right, managed with BCS with type 1 mammoplasty with axillary lymph node dissection. There was a case of right-sided thyroid nodule managed with right-sided hemithyroidectomy and one diamond cyst behind right ear, which was excised. In emergency admissions, there was a case of epileptic perforation managed with laparotomy, acute calculus cholecystitis.
Someone is laparotomy. Something is done with laparotomy.
Yes, sir.
What do we have? Repair.
Laparotomy and repair. Acute cholecystitis managed conservatively. Acute appendicitis, total 3 cases was there. 2 male and 1 female. Left foot cellulitis with T2DM and H10 managed conservatively. There were 2 cases of diabetic foot ulcer managed with debridement and dressing, and 1 case of perianal abscess, which was done IND. In emergency operation section, there was right obstructing inguinal hernia, right inguinal herniorrhaphy done. Acute appendicitis, appendicectomy. There was a case of perianal abscess, IND done. Diabetic foot ulcers, debridement and dressing done in 2 cases, 1 male and 1 female. Right inguinal lymphadenopathy, right inguinal lymph node biopsy was done. This was a male patient, and 1 case of parietal abscess was done, in which IND was done. And these are minor procedures. Two-cut biopsy, 4 cases, excision of sebaceous cyst, 15 cases, lipoma excision, 3 cases, papillomatous growth excision, 5 cases, IND of abscess, 10 cases, foreign body exploration, 3 cases. Regarding morbidity and mortality, mortality was nil, but there are 2 cases of morbidity. Morbidity 1, a young male underwent Roux-en-Y hepatogenostomy and excision of choledochal cyst due to type 1 choledochal cyst. In the POD1, abdomen was soft, hemoglobin level was 12.1%. In POD2, abdomen becomes slightly tense, bowel sounds audible, eventually whole abdomen was within normal limits. Patient was kept on NPM and IV fluids, but from POD1 to POD5, hemoglobin levels started to decrease. There was blood oozing from the drain site. He was given about 4 units of blood transfusion intermittently. Patient was kept on IV fluids and MPN for next 2 days. Abdomen was still tensed. He developed more blood discharge from the drain site and severe respiratory distress. There was increase in total count, and ABG was done, which showed abnormal parameters. So patient was shifted to ICU. After 2 days, patient started having biliary discharge from the OT side. Abdomen became more distended and tense, profuse biliary discharge from the OT side. Re-exploration was done, lavage given, and RPM drain and pelvic drain was given. The patient is still admitted in ward, but the drain output is very slowly decreasing. Patient started taking soft rice diet. Wound sites are also healing slowly, and we are planning to discharge the patient as soon as possible. In morbidity 2, this was a case of umbilical hernia in an elderly female who were admitted in our hospital. Mesh umbilical hernioplasty was done. POD1 was uneventful, but from POD2, she started having discharge from OT side. No history of DM and TLC was normal. Fresh dressing applied. POD3, patient becomes slightly disoriented and hyperkalemia noted. Potassium supplementation was given. Wound discharge continued, and we used to change dressing every day. But this patient got and after the regular dressing, we discharged the patient. But as the wound healed, but this patient got again admitted few days ago with wound dehiscence around the OT side. However, this was not much deep and not damaging the sheath. We initially tried with normal dressing and other supportive management, but now we shifted the patient to vac therapy. The patient is now responding well, and the wound is slowly healing.
Go to emergency operation. Right obstructed inguinal hernia. What is that hernia? What does it contain? It could, the primary diagnosis was intestinal obstruction.
Really sorry.
What? You have to differentiate between a irreducible hernia and obstructed hernia. What is the difference? What is the difference between a irreducible hernia and obstructed hernia? Both are irreducible. How do you differentiate? Because you see, these sort of patients keep on coming to emergency. And when you scan these obstructed hernia, these irreducible hernia. What feature patient will have if the patient has got an obstructed hernia?
The features of intestinal obstruction.
Yes. Now the question comes, is it a simple obstruction or is it a strangulation obstruction? Because management will vary. I find he said obstructed hernia and a herniorrhaphy. Patient having a simple obstruction you can proceed and put a mesh. Because putting mesh is the standard of care. So it's not contraindicated that in a patient who has got obstructive hernia, mesh placement is not contraindicated. But what precaution you should take? When you are operating on a patient who has got an obstructive hernia, what precaution you should take while tackling the hernia?
The proper aseptic.
That is, you have taken. While doing surgery, what do you do first? You will release the ring first or release something else first? Patient has got even obstructed hernia, there may be some toxic fluid collecting near the fundus. So in that case, you should open the fundus first. If there is some toxic fluid, that's not obtained. And now you decide, is it strangular hernia or obstructed? In obstructed hernia, you reduce the hernia, and then you do the standard hernia operation. There is no contraindication. This right inguinal lymphadenopathy was done in elective. Why do you put it in the emergency operation? I remember this patient. Huh?
On the emergency day in the
No, it was not emergency day. It was elective day. Huh?
it is not done.
Your data should be correct. Dr. Kaur, any comment to make?
Right inguinal herniorrhaphy, he has said, well, it is an obstructed hernia. There is no comments about the gut. What was the condition of the gut? What did he do? It's just herniorrhaphy. The obstruction was relieved. How was it relieved? What was the next step?
Where is obstruction? In a obstructed hernia, the hernia get obstructed at the neck. Hernia can get obstructed at the cervical ring. Hernia can be obstructed by adhesion and kinking. What are the obstruction site in this patient? How could you relieve the obstruction?
It's in the neck region.
In the neck region. And then, if there is a neck region, there is usually a mark. Then how do you decide? The gut is gangrenous or not, gut is borderline. Suppose gut is appearing borderline, there is some congestion. How do you decide to resect or not to resect?
It's a,
How do you decide this gut is gangrenous, this gut is borderline, this gut is fine?
it's a color of the gland or
Color. What else?
yes,
Color.
peristaltic movements.
Yes. And color of the gut, peristaltic movements. What else?
And patient's clinical.
Patient is under anesthesia. What do you see? Patient is on the table. Third is, you can feel the pulsation of the vessels in the mesentery. If you can feel the pulsation in the mesentery, you find the color is good, peristaltic waves are coming, it's a viable gut. It's a borderline gut. What do you do? It's a borderline gut. Somebody is saying, nee, gangrenous hai, somebody is saying, nee, theek hai, but it's a borderline situation. What to do?
Applying hot mop.
Hot mop. What else?
For oxygen.
What else? If the patient is
Highly concentrated.
patient is on a operation theatre, you don't have HFNO here. You ask the patient to stop nitrous and give 100% oxygen. Okay, give the patient 100% oxygen, put hot moist mop and wait and see whether the color returns, whether the peristaltic wave returns, and you can see the pulsation.
Sir, how much time we can wait?
At least 3 to 5 minutes. Okay, so in that case you reassess.
Actually, sir, this patient came with obstruction and she was having hemoglobin 3 and hernioplasty was only done, not raphy.
That is Diptaman's way of looking at things.
Mesh hernioplasty
Why
was
she
only
has 3
done.
hemoglobin? What is the explanation for such low hemoglobin?
She was very malnourished, not taking food properly. It was nutritional cause only. She was very cachectic. So we just did a reduction and we did a hernioplasty within 30-40 minutes and we came out.
The gut was viable.
Gut was viable, sir. I mean, it was starting to go into the gangrenous phase, but it was we were able to recover.
So I will ask all the residents to keep on noting day to day the morbidity of this. There is a lot of learning from the morbidities. you know how to manage post-op morbidities. You understand what are the different morbidities we may have. You see, you are working in an environment where you have some senior people around. You'll be working independently. So don't ignore these morbidities. Try to analyze the morbidities, why this is happening. Try to understand whether you could avoid this. You see, patient has got a wound collection. So why this has happened? Wound collection, maybe one reason is while I was doing the surgery, I was not very meticulous in doing hemostasis, so there is some bleeding and it results in collection. Second issue is patient may have pustular infection. So if you have number of patients having a hernia surgery and then having infection, then you have to review our whole practice. What you are doing. So I request all the residents day to day when you take round, your every unit is having an average of 35 to 45 operations in a month. So I don't agree. If I operate 30 patients, 2, 3, 4 patients, we'll have some complications. We'll have some deviation from the normal route. That is what is the usual norm. After doing 3 units saying hey, they have done 100 operations, they are saying morbidity is 0. It's not acceptable. You are overlooking. So for next time on, you should note day-to-day practice. You should know the deviation what is happening and why this has happened. Try to analyze, and then you see how you have managed the situation. If a patient who has got a biliary leak, that patient can only manage constipation. That patient has some. Why you have decided to explore? Because this patient on the 7th post-op day was having pain abdomen, was having a tense abdomen, which has turned around. There is a guarding. So if you have a situation like this, you have to take a decision that this patient needs a reapproach for drainage. Because you put a drain, it was draining initially, and then somebody is not draining. It's not that there is no collection. Can block. So that is the idea of doing a post-op reassessment. If you have a surgical complication, the idea is to identify the complication the earliest and then do some intervention. And that intervention sometimes may be radiological. If you have a good radiological backup, you can put some age-guided catheter placement. So whatever you have to decide how to manage it, because we lose. There is a saying that no surgical patient dies suddenly. A lot of surgical patient gives us a signal. If you ignore the signal, patient will die. So try to pick up the deviation from the normal recovery. As I always say that patient who has got a lab coli, normal recovery is same evening patient may asking for drinks. Next morning patient should be comfortable. Patient should have a nice sleep at night. First post-op day patient should be liquid initially, can tolerate semi-solid in the same, and by 40 days should be back home. So patient who is not sleeping, patient who is crying of pain all the time, something is wrong somewhere. You just cannot shout on the patient that you are unnecessarily disturbing. If the patient has got unusual pain, you have to address that pain. Okay, so keep a vigil on this part, what I'm trying to say. And then you see, this audit is a comprehensive audit. The better audit will be if we say that we do an audit of lab cholecystectomy at MRBH. So that is an audit for a particular procedure. That will reveal us what we are doing, what percentage of gallbladder size you're doing laparoscopically, what is our conversion rate, what is our bile duct injury or other injury rates. And you see, at the moment, if you go to mortality, it's negligible. It should not be happening. So that is a audit focused on particular. If you talk of wound infection, you see, if you do an infection audit for last 3 months, then that gives us insight how we are going. How is our ward environment? How is the theater environment? Okay, and if you do an audit for the infection, you can find out what are the bugs which are causing infection in our setup, what are the sensitivity pattern. So next time, apart from comprehensive audit, we go for some specific audit. Okay. Any comment from any other? Dr. God, thank you.
Thank you. Okay.
Thank you.
Thank you, sir.
Thank you.
হয়ে গেল, চলো জামা কাপড় পরে পুরো মিটিংটা অ্যাটেন্ড করলাম, প্রত্যেকটা মিটিং এ ইনভাইট করছে আমাকে।